Welcome, everybody. We already started. We're so happy to have this kind of reunion, this kind of activity. We are here in the Oftalmo University campus, Mexico City. We have Lisandro in Barcelona right now, who's going to be the host of the entire activity. And we have two great colleagues, two great surgeons, and two great friends. And I hope that during the meeting, many people can join us, because the idea of today is to have an interactive session. This is between us, between colleagues, between friends. We're a big family here, and we're going to be here with simulators. We're going to show you completely disruptive things. We're going to show you things that only you're going to see here, because we are in the edge of innovation and software development for simulation. So welcome, everybody. We're going to start doing a lot of these activities. This one is especially for Europe, Africa, and Asia. In Asia, it's a little bit late, but I hope somebody is still awake. So, Lisandro, thank you for preparing everything, and we're going to wait for your introduction.
Hello, everybody. Hi, Ivo. Hi, Florian and Atanas. Thank you for being here. Yes, I will start just sharing my screen, just to a small introduction, and after that we will discuss some interesting stuff. Let me see. Okay, we start with problems. I cannot share. That's something new. Oh, it's not letting me share.
Don't worry, we need to talk to the Zoom team, because every time, every month
Exactly.
that passes, they make it more difficult for people to
use it. They changed the settings and the options, and everything broke. So can you start making the introductions, and I will try to share this.
Sure, definitely. Let's start strong now. So basically, what we want today is to understand what's going on around the world in surgical training, especially cataract surgery, in what is changing, what can you do in order to become an excellent surgeon. And this not only means to become good to the operating room, to become competent, but then to become excellent. So in this journey to become excellent, I think we're seeing a completely new, because it's not only technology, we're talking about simulation here. We're talking about a simulated experience. We're talking about methodology. We're talking about mentorship. So we want to show you, and we can show you right now, we have two students in this case. We have one student from Mexico, another student from Bolivia. They're doing cataract surgery. They're doing retina surgery too. And what we're going to show you is how not only fidelity, I mean software, I mean what simulation relates to the real life, but also the methodology. So I'm going to start with this. Rodrigo, we're going to put 3 screens now. So we're going to show exactly what our student is doing. Okay, so in this case, we're going to see cataract surgery with the software that Atanas and Florian trained in the past. Let's say between 6 months to 1 year. We have both of them here. So by seeing this software, I would like for you, Atanas, to remember the first thing that comes to your mind when you see this software. We know that you are going to have this software available for you in Germany in a couple of days, couple of months. So what's the first thing that comes to your mind when you remember these images and these videos?
Oh yeah, so just a quick note, I was there with you, I think it's over an year now, a little bit over a year. And the first thing that comes out to the, I used to do simulated surgery before. And when I tried this out, I mean, the first thing on my mind was this lens feels different. So it's much more realistic. It handles better. And I think the fluid dynamics are very, very close to realism here.
Excellent. So remind me, when you trained here, you were we had the old software by that time?
We had the old software, but we had the new software as well. So we
Yeah, we
could
were
combine
trying the
both.
new software. Yes. And with you too, Florian, right? So let me do the introductions again. Atanas, we're gonna introduce him, great surgeon, great friend, and now living in Germany. And Florian, another great surgeon, another great friend that recently moved to Austria. So Florian,
Right.
again, the question is, when you see that software, the first thing that comes to your mind?
I think that the new software has been very realistic, and it has challenged one to be more cautious, more careful, and especially with sonular lysis, for example, putting pressure onto the capsule. And it has been possible to have a very realistic feeling of divide and conquer as well as the chop technique. So it's yeah, definitely a big step forward for simulation, I would say.
Let me show you guys another thing. Muévete un poquito para mí. Más, escúchame. Mueve un poquito. So let me show you another thing in the big screen. Rodrigo, put this screen big, please. This is a second thing that I really want to show you. Okay? We're going to put it in the big screen. Dile a Rodrigo que ponga. Okay? So, you know what's happening there? What is happening there is called a time lapse. What is happening there is the task he did, like, let's say 10 minutes ago, is moving forward very fast, but is going to stop either when he makes mistakes or when he does everything that it's him asked to do. In this case, he's doing phaco-chop. He's doing phaco-chop with the entire lens, which is actually a very complex task and not easy to do. And he could do it almost perfectly. And the machine is going to tell you exactly, objectively, which is your score, first thing. And second thing is if you did mistakes and which mistakes. So the next time you simulate, you can improve it. I would like also to first Atanas and then Florian to tell me how powerful it was in your training to have objective feedback when you were training. Atanas, what do you think?
I mean, this was basically the most advantageous thing to simulation because it's not about stimulating the movements. It's not about performing the tasks, but it's also pausing after and reviewing them. And this is something I picked up and I use during my routine cases. I actually try to take recordings of all of my surgical videos. We do have this option in Germany. And each time that I get the chance, of course, free time is not abundant, but each time I have the chance, especially if I had some trouble, complex cases, I try to go back home and review the cases and review those key points, try to take some feedback, try to learn from myself and watching myself perform them. So this is probably one of the best thing that is a simulation.
Amazing. And before we go to Florian, I want to take a couple of minutes to thank everybody who is here with us. We have so many people from Europe. I want to welcome you. I want to tell you, that this is completely interactive. Please use the chat. Please use the questions and answers. This needs to be for you. We really want to help you in this journey to become a cataract surgeon. We want to say hi to Nelly, who was training with us too. She's from Estonia and now in Finland working. There is so many other people, who are close to us. So we would really like to say hi, and please tell us where you are, in which moment of your learning curve, and please let us help you in that journey, and we can become you can become part of the family. There is another person I really want to say hi, that is Catalina Dimitrescu, who is amazing, has an amazing, group of people and always sharing knowledge. So before that Lisandro starts sharing the introduction, let's ask Florian about the objective feedback. Florian, tell us a little bit. How important
Yeah,
was
so-
this curve?
What I found amazing about the simulator and really good what you don't have in the actual surgery is the quantitative feedback. Sorry. And
okay,
so the
Florian.
quantitative, the quantitative
We all have
feedback.
kids.
Yeah, that's right. And they're very nice, by the way. And so the quantitative feedback that you get numbers, and those numbers really help you to see in which area you had difficulties and how big your difficulties were. So if you have a lot of traction on the sonula, you get a quantification of how much traction, and something which you only notice in real life surgery once the complication happens. So this really helps to fine-tune your movements and to fine-tune your training. So this is what I found really great about the simulated surgery with the simulator.
Perfect. And how do you think, or maybe do you think it will be useful to have something like this, but analyzing your own cataract surgeries videos? I mean,
Sure,
an
definitely.
objective feedback for your videos.
You mean like an objective feedback for
yes,
the videos?
like
Yeah,
something that measure all the movements inside the eye, track all the instruments.
that would be certainly
etc.
amazing, because it really, I think once you get to a certain point in cataract surgery, it's about becoming more efficient, right? You shouldn't be fast, but if you have something that tracks your motion, I think if it's even automated, probably you can very well notice where you can be more efficient, and so it makes your cataract surgery probably quicker and safer at the same time.
Yes, like Ivo used to say, you cannot improve what you cannot measure, and giving or having a tool that measures all the things, all the variables in your surgery, I think it will be amazing to have something like this.
Definitely.
Okay, I will start sharing. Let me. Okay. Now, can you see the presentation?
Yes,
okay. So this is a small intro about what we are doing, and we train ophthalmologists to become competent cataract surgeons. And I think that the key word in there, it's competent. What do you think that it's a competent surgeon? That it's something that we discuss with Ivo a lot of times, and we are getting into some key points of being a competent surgeon. But what do you think, Atanas or Florian, that has to have a competent surgeon?
Yeah. Maybe I can go first, if you don't mind, Atanas.
Yes, please.
So I thought about it, and I think competency means for me that maybe one aspect of competency is knowing your limits and also be willing to improve. So if you want to be competent, I think even a beginner surgeon can be competent in a certain way. So he needs to know what he can do and what he is safe doing. And then he needs to know where to have help. And then being more confident, being more safe, then he can become more competent. But I think to be competent also means to know your limits and to be able to work on your limits. Because if you don't have that, I think that's one important thing that you need to have if you want to become a competent and to be a competent cataract surgeon.
Nice one.
I completely agree. I believe exactly as you said, Florian, like knowing your limits is a big thing about competency. I would like to describe it the way I see it is like becoming competent in a task is exactly the time that you feel comfortable doing it. It's very easy and you actually start really enjoying it. It's not stressful anymore. It feels easy. It feels that everything is flowing. So
Like a flow state.
exactly like the flow state. This is where true competency kicks in, because now instead of only focusing on the movements and the task itself, you can actually stop thinking about the bigger picture. Hey, am I spending too much time on this? Where can I improve? So this is the next level of your actually mastering the task.
Nice one. I completely agree with you both.
And let me,
Yes,
if I
yes,
can,
please.
Lisa,
Yes,
let me add,
course.
let me add something, because as you know, I'm completely obsessed about this. I think we really need to think about what's happening today with us, with so many people around Europe trying to train, trying to become good, trying to be the best possible surgeon. And when people talk about competency, my opinion is that the real question, sometimes it depends. And we need to be aware of that. What happens when you work in a big institution, when you have the retina specialist right next to you? Or what happens if you're in private practice in a small clinic with a retina specialist 400 kilometers away, right? I mean, don't you think that that concept changes? So I think it's extremely important to understand that competency is something we need to try to achieve like in the best possible way. Also, I don't want to spoil what you're going to talk about, but I think we also need to talk about safety here, and safety for our patients. Because sometimes, every time people say, what is competency? People will say everything is about the surgeon. But really think about it. We are going to be, either us or some family member is going to be a patient at some point. And they're going to have a surgeon trying to do surgery in themselves. So what about safety for our patients? That is why we believe that simulation is changing the game completely and should be more used. Sorry, sorry for that comment, Lisa.
It's okay, you and like I said before, these three points that we are going to see right now are something that we discuss with you a lot of times. And one of the points is repeatability of you being consistency, like or reliable when you do something, and you can make the same things over and over again. And of course, we are talking about making a good thing and not a bad one, not an error, but being consistent in your cataract surgery is one of the key components of competency. The other is being able to complex cases solving. So maybe in our first surgeries, maybe we can complete easy cases, but I think that one thing that we must improve is to being able to solve complex cases. Because during our residency, maybe they allow us to train with easy ones, but when we are facing a private clinic, like Ivo said right now, maybe you're facing complex cases and you need to solve that. And the third one is complications. If you have to confront complex cases, you will have complications, and you have to know how to manage that. So competency, it's a combo of these three pillars. And one of the problems we see in LATAM, this is a survey we got like 2 or 3 years ago from LATAM. These are colleagues from LATAM, and we saw that in most countries in LATAM, they didn't get enough training or surgery training during the residency. And we saw that this was a problem for LATAM and about LATAM, And then when we got the numbers from Europe, we see exactly the same situation or even worse in some countries. So that was a surprise for us. Can you tell something about your residency in Europe, and how about was your training, your surgery training?
Sure, I can be quite quick. Yeah, so residency for me meant no surgery. I think yeah, so it was in Germany, and I think it's similar for many. It's quite common, but some people are lucky to have some surgery and even some intraocular surgery. But I think for me, it was no. So I would do the no surgery part. Did you have the opportunity during residency to learn cataract surgery? No.
I didn't. In Latam, my situation was exactly the same as you. How about you, Atanas?
So I did my surgery, my residency training in Bulgaria. I didn't get any surgical training back then at home, and I'm actually currently working in Germany, and I can see the resident, and I can confirm what Florian's saying. Like they get little to no surgical training. In some big university hospitals, they do get some training on how to do like sutures, eyelid sutures, and like wound revision.
But not phaco training.
But not phaco training, not at all. So
Wow.
we are lagging behind.
Yeah, and Ivo, are you there? Because Ivo has some
Yes.
paper published. Can you
Yes,
share
let
the
me
paper?
let me show this, guys. Let me show this. And again, this is an amazing research paper published by Dr. Sorka. I can't say the last name. Probably Atanas or Florian can help me, but it's going to be impossible to pronounce the last name. It's very difficult. But she did something amazing. Look at this. She did a survey in many countries in Europe. And what you're going to see there is, of course, the amount of responses, was it more confident or less confident. But you're going to see in the first column how many procedures partially people perform. So I want you to at least see three or four countries that people are doing high volume. United Kingdom is one of them. Turkey is in around the middle. Then we have other countries like Latvia, and we have other countries with high number like Netherlands, Ireland, France. No, sorry, France is not that high, and Cyprus. Okay, but removing those countries from the list, I want you guys to really look about how many partial or total procedures people are doing in Europe. And in the other columns, we're going to talk about the confidence level. So even in countries in where they do, let's say, 40 cases to 100 cases to 150 cases, still the confidence when they need to do challenging cases or manage a PCR, for example, confidence is low. So I go back to my first questions. When are we competent then? Is it a number? Because people like to see a number, right? Oh, I did X amount of cases. Oh, you did X amount of cases. Great. How many anterior vitrectomies did you do? Right? So I think that's one of the things we need to really practice. And one of the things I want to show you guys now with our students is the performing of an anterior vitrectomy, which you can train in virtual reality. And I know what Atanas and Florian did great anterior vitrectomies here. What do you think, Atanas, about the capability or the possibility to train anterior vitrectomy even before you get to the operating room, actually?
That's a very good point, Ivo, because if you think about it, talking about mastery and talking about being like capable of performing the procedure, even if you're training phaco with a mentor on patients, you're actually not training to handle complications as long as they don't occur. So usually what happens is if something tends to go wrong, the attendee takes over immediately. He just stops you. you switch, and then he takes over and he tries to handle the case. So he doesn't give you this extra step of, okay, wait, you know what? I ruptured the posterior capsule. Let me handle it. And this is something that is with a simulator, it's gonna unlock a whole new system that allows you actually to practice many different complications in many different ways. And it's going to be advantageous as soon as you unlock as soon as you get to your first complication. And this is going to happen. If you're a surgeon, you're getting complications.
That's true. Yeah. And some important thing that it's related exactly with what Atana is saying is that besides you can handle all and practice all the handling of that complication, you don't have the pressure of being with a patient. So you're putting all your brain power into learning how to solve a complication without the worrying of being with a person, with a patient, with a complication. So that's not a small thing. That's a big one. You are only learning how to solve that without the worries.
What about you, Florian?
Yeah, I mean, I think the worries get big when you have the complication in the operating room. So being prepared is really, really helpful, and it will help a lot, like the whole cataract surgery simulation. I mean, it really will help a lot to do all steps of the simulation to be prepared. Let's put it that way, because I don't know if one can expect from yourself to be confident, because the stress level is, I think, too high. But definitely, it really, really helps to be prepared.
Exactly, but you will be more confident than if you didn't train with the simulator.
Yeah.
So that's a big one.
Yeah.
Ivo, we are not seeing the images from the simulator. I think we lost you.
Okay, we have also. Yes. Dr. Oliver Garcia here. Okay, he's going to be here with us, and he's going to.
How are you?
Show you.
Hi, Oliver.
She's going to show you a couple of things that not even Atana or Florian were able to try here. Look at this, guys. You are one of the few people in the world to be able to watch this software. So we have a great surgeon now from Mexico, and he's going to be coached by Oliver. And guess what? He's facing a really hard cataract in which you can change all the scenarios. So Oliver, please.
So at this moment, Alan is doing a hard cataract. He's trying to do the skull, but let's stop for a second. We're going to do is go outside. 1 second. Okay. We can change all the settings. Let's take back. So I don't know if you can see, Rodrigo.
No, we are not seeing that.
Yeah.
The screen.
Okay. No. Acá, podemos enfocar acá. Sí, pero so if you can see, we can change. We are going to make software Alan. We are going to put a loss of sonula. The rexis is small, 4.5 millimeters. Also, the hydrodissection is not completely done, so it's sticky to rotate. Then he must not have sonnular support, weak, and a medium cataract, and it's all, okay? So this will be a different scenario. Small rexis, he will battle to take out the cataract, hard cataract, and sonnular weakness, okay? So you can continue talking. How are you, Atanas? How are you, Florian? Nice to see you
Very
again.
good. Yeah, nice to
Great,
see
nice
you.
to see you again, man.
So I will be back as it starts the task.
Rodrigo, can you show us the simulator screen, please?
Yes. So keep discussing while the task is charging, because these are completely new tasks, which are very heavy because, you know, they're the first time we're
Okay, so the thing it's happening right now, it's the new software can allow us to manage or to tweak the case in all the details that we want. So we are making it like a difficult case with all the elements that we need to simulate that. And that's why it's taking so long to start, because it's a new case for the simulator.
So it's you need to do hydrodissection too in this case.
Exactly. It's not done completely. It's halfway done.
Okay.
So look,
Interesting.
we have already the case. We have a hard cataract, as you see, it's kind of brown. He has a small rhexis. I don't know if you can see it correctly, but it's more or less here. So Alan is going to start, and then we have at the top and there.
Yeah.
At the top of the screen, to the left, we have the ultrasound, the aspiration, and the irrigation. But what is new, at the right, he has the exact point where the phaco handpiece is doing the sculpt. So if he goes too deep, he's going to break the posterior capsule, and he can notice where he's doing the task. So Alan is doing a great job. He's kind of having some troubles because the rhexis is small. So he cannot go too deep and not too long. Now he's going to use the second instrument.
So
And
that thing
I don't know if
Yes,
you noticed where is the sonular weakness. He's trying to do the cracking, but it's not deep enough. So it's not easy. It's a real one.
It won't be able. He won't be able. So the thing that Oliver was saying, it's if you see the screen, the simulator screen in the upper right corner, you see that handpiece in blue, and you can see how it's moving on the depth of the point of the tip of the phaco. That's a new version of the software that Ivo was talking about.
And one other thing, guys, if you focus your attention on the upper right part of the screen, I actually never saw this, but you actually get a 3D side representation of the lens, and see how he's pressing and pushing the lens down.
Exactly.
Oh, wow, that's so cool.
That's new one. Yes.
I would like to
American.
ask again Atanas and Florian and all the people who is here with us, how important do you think it is in your learning curve, not only when you are before, you know, preparing to enter to the operating room, but during the operating room experience to face cases like this? In this case, he can be facing a hard cataract with small capsular rhexis, with sonular weakness. Something that also changed now is that when you see the visibility of the anterior rhexis is not that clear, that's going to happen for you sometimes in the operating room. And especially that side view that in this, for example, specific case is going to tell him how much pressure he's putting in the sonula. these are things that you don't see sometimes in the operating room, and you don't have that feedback. What do you think, Atanas?
Well, I believe personally that the more information you have, the better, especially earlier in your learning curve, because sometimes you get complications and you are not aware, what did I do wrong?
Sorry. Now look what's happening.
Yeah.
He has some troubles because he has weak sonula. So the cataract is, the hub is in the retina now. I don't know if you can see it. He has some
It's
troubles.
dropping. Yeah.
But that's important. It's the first time he do this hard case and he can improve.
Nice.
Yes, exactly. And then if you go to this previous screen, you can actually pinpoint the point that actually happened. So you can slow it down and go back to it. So if you notice in the bottom, those green things that you see, these are actually feedback from the machine. So you're getting them live. If you're rupturing the zonula, you actually, it says it, careful, you're putting too much stress on the zonula. So you get this live feed. But then again, you can stop at the end of the case, you can go back and pinpoint each and every time it happened.
Exactly. And you can have also an audio feedback from the machine. You have a visual feedback and an audio feedback telling you what are you doing wrong in a live.
And I have one question in the review. Can you see the symbol from the upper right corner as well? I was just wondering if you review the video, but it doesn't matter. But
the time lapse screen.
Time lapse, yeah.
Okay. I don't know. Ivo.
Yes.
If you go to the time lapse screen, you can also see the upper right drawing.
I don't understand the question. You can see what? Sorry.
Question is, can you see the side view, the like the lens from the side?
The side view.
Side in the review mode.
No, not yet.
Okay.
Yeah.
When you're reviewing, not. You see only the simulation.
Okay.
But again, I think something happened here, and we need to talk about it. You know, a mistake happened, a complication happened. So one of the things that people sometimes don't understand, because let's be honest here, I'm pretty sure that when Atanas or Florian were making the decision to come here and do a simulation course, many people came to them and said, what? Really? What are you going to do simulation? Why don't you go to India and do 30, 40 cases? Tell me that that's not true, because that's going to happen to everybody at some point. So think about what happened right now. So what happened right now was a complication. We saw it. It didn't have a consequence for a human being. And we are learning from it. We understood what happened, where the mistake was, and guess what? We can go right back and do it again, and again, and again. And we have a mentor sitting next to us. So how powerful is that? So because I think if you ask me, which is the objective of this talk today, is exactly that. To understand that, you know, many things changed in the learning curve and in the training of a surgeon. And fidelity went high now. And now we can train, for example, look at this. We're going to see Dr. Sorsby training for an anterior vitrectomy. He's going to start doing irrigation aspiration, and then suddenly that capsule is going to break. So he's going to be training in something that happens with low frequency. And most of the times, people, what are going to do with you? They're going to remove you from surgery, right? They're going to say, okay, go to assist me, and somebody else is going to solve it. So again, Florian, what do you think? How important is to train for complications in a simulated environment? What do you think?
Yeah, I think it's very important. And I mean, I think the one big difference we haven't talked about is because you talked about the mentorship, that also the mentors or the trainers, it's much more relaxed for them. It's not only the trainee. So in the OR, you often, if you try to train somebody, you are like on fire, you're very nervous.
Normal.
You know, you need to look for the best of the patient. So obviously, people like to take over themselves because they say, okay, now already the complication happened, and now we want to prevent further. But in this environment, you can safely practice, and then also your mentor, your trainer can give you tips. Let it be the hand positioning, for example, or anything else which he could not even observe during a real life surgery. So you get so much more feedback. So I think complications happening and also training in the simulated environment is very important, not only for the trainee, but it also really helps the mentor or the trainer.
Quick question to you guys. How many residents do you think train and are competent in anterior vitrectomy? What do you think, Atanas? In the world?
Oh, wow, that's a very good question. I think few, but actually this is changing. If you look at the state, I mean, I don't know if you guys saw this, but the Mass Pioneer, the Harvard clinic that actually trains residents in the US, actually featured simulation surgery in their residents training video. And there are a lot of training centers in the US and UK that actually implementing like not a mandatory, but a suggested simulation training as well, and wet lab training before actually residents going surgery. So this is not taking place right now, but it's picking up, and it's going to be a standard in the future.
Exactly, and not only because of the safety of the patient, but I think that nowadays it's like an ethical question. You cannot go to a real patient without being in a simulator. I think that's an ethical question.
I agree, yeah.
So let's talk about this. Andrew, on purpose, did a couple of mistakes, but actually I can be honest, that is what we mostly do in the beginning, right? Basically, when we're doing vitrectomy, we see vitreous, we go for vitreous, and we don't have the most important principles into account. So Oliver here is going to explain you what happened with all those metrics. I hope you can read them.
So at first, Andrew paused the irrigation. So that's important in anterior vitrectomy, because if you pause the irrigation, you collapse the chamber. Then he don't completely remove all the vitreous. He removes, I don't know how much, I don't know, more or less 72% of vitreous, but he remains leaving vitreous at the chamber. And at the end, he don't put viscoelastic when he finished the anterior vitrectomy. So again, the anterior chamber collapsed. Now Andrew will do the task again, but try to improve these kind of things.
That's the objective feedback that Florian was talking about. You get all that small details to improve, and you can measure it, and you can improve it like in a visual way.
Now, first, we have to put continuous irrigation, as you can see. And then Andrew will start doing the ANI aspiration. So he's doing the irrigation aspiration. He noticed the posterior capsule rupture. He remains with the irrigation inside the eye in step 1. He changed the parameters to continuous irrigation. And now he can start doing the anterior vitrectomy. First, put in triamcinolone. Then viscoelastic, OBD. And now he can do the anterior vitrectomy. And also, we can talk a lot about the parameters of anterior vitrectomy, when to do first cut, then aspiration, when to do first aspiration, then cut. And look, what is important here is that Andrew started the anterior vitrectomy at the bottom of the vitreous, not at the top. If he started at the top, he will pull the vitreous to the anterior chamber. So he can be taking out all the vitreous of the eye. And we have only to cut the base of the vitreous. As he finished cutting the base of the vitreous, he can go for the vitreous that is above the chamber. And as he finished doing the anterior vitrectomy, he can now go for the other remaining cortex.
Yes, and Oliver, as you said before, you can, of course, simulate all the settings from the machine. You can lower the cutting rate or high or taking it up and see what's the influence of that settings in the behavior of the eye itself.
Right, because remember, you have to do slow motion phaco if you have still cortex or nucleus in the chamber, or you can also change the parameters of the vitreous machine. It's not the same cutting vitreous as cutting maybe cortex or other kind of things. Also, the IOP of the irrigation, you can change it. You can play with these kind of things. And at the end, Andrew is going to put OVD in the chamber. So no more vitreous is going to go outside. And he can have a stable chamber. And look, at the end, he do a very well job. He have a score of 100. So that's the kind of things you can practice here. You can have mistakes and then you improve.
Congratulations, Andrew.
Yeah, this you make it look easy, but it's not that easy. I mean, I remember first time I did this, like intuitively, you just start like cutting the vitreous, and then you pull more, and then you get a score of 0. So you have to stop and think about it. Yeah, it's a good job you did there.
Exactly. What are we seeing now, Oliver? I think you're mute. We cannot hear you, Oliver.
Looks like a cataract, huh? With a divide and conquer approach.
Yes, but
Good size
now
Rexis, medium
he's
density.
using the old software. As you can see, we are not seeing the side view as we saw before.
So do you have any idea about the software? Is it so it's actually you guys are like beta testing it, right?
Exactly.
Any
Right.
idea when it's coming to all the
No.
simulators worldwide? No.
I don't know. That's something that you have to ask Ivo, because he's the consulting guy.
I see.
I think this time the groove is maybe a little not deep enough again, but we will see.
Guys, we cannot hear you back there at the campus. I don't know if you are mute.
It's not a too hard cataract, huh? It's quite sticky. Now he's going deeper, so I think now there's a chance of cracking.
I don't know exactly what was the settings for this case, but yes, we are seeing a divide and conquer. He managed to crack the first half.
So Florian, you're a surgeon. Tell me, how did this,
Acá, ¿cuántas veces va a venir a tocar lo mismo?
Now
no.
we can hear you, Ivo.
Can you hear me?
Yes,
Yeah.
perfect.
Okay,
sorry.
so can you hear me now?
Yes,
Yes.
yes.
Yeah,
Okay, no. So the idea again, now Oliver is doing with the actual software, hard case. Again, now you don't have all that guidance. Now you don't have all that help. So what I'm trying to say is that in a simulated environment, you also have something called gradual experience. You can deconstruct a difficult task. We're gonna do now also Phacochop just to finish, but imagine the possibility to start doing Phacochop in most simple cases with half of the lens, with not a sonar dialysis, and then you can slowly and gradually start doing something that is more complex. So again, just to finish, Atanas, I'm still thinking about so many people who have connected with us today. So many people are gonna see this when they have some time. Which is your recommendation for them? What can we do as colleagues around the world to help other colleagues in achieving this dream to become cataract surgeons?
Oh, a great question, Ivo. So I personally believe that we first of all we need to be more open-minded. We need to connect more and to share more of our what we experience and the way we learn. For example, I find simulation surgery a great tool, and something that helped me personally a lot. So I'm using all of my personal social media channels to communicate this and to share with everyone who was here, and that actually this could be a great learning tool for them too. The best thing we can do, each one of us, is to learn from mistakes and to learn from the mistakes of others. So try exploring new ways. I mean, I know you could be probably in an institution where we have one surgeon doing everything, or you could be in an institution that has multiple surgeons, each specialized in different tasks, and try to learn from them, but try to expand your options. Try to learn from people that are better. There are so many resources nowadays. So that will be my advice.
and maybe I can add something
Yes.
also.
What about you?
Yeah, I mean, I totally agree with Atanas, of course. But what I learned from you, Ivo, is, and I'm just reminded of it right now, is that maybe one thing we should also do is, once we know the surgery, we should teach others, because when you teach others, you learn for yourself also a lot of things. Like, let it be communication, let it be, but also you need to deconstruct the surgery in much more detail when you try to teach others. So you will really also improve while teaching others. It's not that you teach others and you don't learn. It's actually you learn while you're teaching others. That's what I would like to mention also.
Perfect. Let me add something. As Atanas says, learn from mistakes, but without the patience in the other side of the microscope. That's the perfect situation.
Completely agree. One thing that I wanted to say quickly is, actually, I would also like to share a personal memory. When I was in Mexico with Ivo, he actually, the way he teaches, the way he does his mentorship is he we were two people practicing on one machine. So one of us was actually performing the task, performing, for example, capsulorhexis, and the other one was observing him from the side and actually was giving him feedback. So you may not be fully competent in the task, but looking the task from the side gives you an extra perspective that gives you ability to share unique feedback.
Very
Exactly.
nice, Atanas. I agree so much. And exactly what happens in a simulated environment is that we generate an ecosystem. Actually, I remember you teaching. I made you teach. And imagine the power of you learning something and then teaching it right away. It makes you learn it even better. That's already demonstrated by science. So you can actually have a problem and two people need to solve it. So you're discussing about fundamentals, then you need to teach. Then you have a very difficult task, which I'm not going to teach you. You know, you're going to need to learn it by yourself. And imagine how you put all your skills to work. And talking about skills, I really want to tell to all the people who came with us that we're going to keep doing many workshops and things about what we call the 3 pillars. If we grab a surgeon, and I'm pretty sure that Atanas and Florian are going to laugh because I asked him like 100 times when they were here about this artificial division of what skills a surgeon should have. Remember that when you come here, you're gonna train in psychomotor skills because this is microsurgery. We also talk a lot about cognitive skills, decision making and problem solving. But most of all, we are now training a lot in this that is called the mindset skills. Okay? It's so important to train your mindset skills. And I'm going to give you just a quick teaser here in this camera. Look, we read a lot in the campus, and we are going to design this program. It's called the Peak Surgical Program. Peak, meaning that we're going to have a peak performance. We want peak performance for every single of our students. Okay? This is about health. This is about nutrition. This is about recovery. And this is about mindset. And we need to train about this in a simulated environment. Guys, again, this is about all of us. We had so many people here today with us. We're so happy. We need to remember, and Lisandro is going to tell you a little bit. Lisandro is now based in Barcelona, Atanas in Germany, Florian in Austria. The family is growing in Europe. We're going to be present with amazing workshops in Barcelona. But before that, we're also going to be in Europe doing other things. And just to finish, Lisandro, I don't know if you have any more information for people who are interested in doing something with us.
Yes, let me share the screen. This is the thing that we were talking about just right now. What our course are with this new methodology that Ivo is expert in, and these 3 pillars that that Ivo talked right now. And of course, we have a community of mentorships. So we have these phaco mentors, refractive mentors, dry eye mentors. We always talk about community because, like Atana and Florian, we are part of a community and we share knowledge. And it's not only about the course itself, but this community of colleagues sharing things. That's a powerful one. And this is the QR code to go to our landing page. So if you are interested in taking these courses, just fill in the form in there, and we will be in touch with you. So that's it, Ivo. Ivo? I think we lost him again. So thank you guys. Thank you for being with us and for sharing your experiences and your testimonies of have taken this course with us. And now you are an expert surgeons doing your
Poné la
jobs.
cámara grande.
countries. Now we
Just
can hear you.
sorry. I did an Evo thing because I really wanted to show, I moved the camera on purpose. So I disconnected the camera because I wanted to show you guys this. This is our small map in which we have all the family. Of course, Atanas is here. Of course, Florian is here. Of course, the map, it's South America, North America, but we have a lot of students from Europe now who are coming. So we will be more than happy for you to be part of the family. So thank you, Atanas and Florian, for your time. We know you're really busy with a lot of work, and you made the time to be with us. Thank you so much.
Thanks
You're
for having
very
me.
welcome.
Yeah.
Yeah, it was a pleasure.
Thank you.
Bye-bye, guys.
Okay.
Bye-bye.
All right.
See you soon.
See
Bye-bye.
you.